So next one lecture, this is oral mucosa, odontogenic infections, and sepsis. Today we'll talk about leukoplakia, erythroplakia, Aphthous ulcers, traumatic ulcers, actinic cheilitis, and so on. And part 2 is tongue development abnormalities, congenital lips abnormalities, odontogenic infections, sepsis, and septic endocarditis. So first of all, we'll talk about leukoplakia and erythroplakia. Leukoplakia is defined by the World Health Organization as a white patch or plaque that cannot be scraped off and can be characterized clinically or pathologically as any other diseases. This clinical term is reserved for lesions that are present in the oral cavity for the no apparent reasons. As such, white patch caused by obvious irritation or entities such as leaking planets or candidiasis are not considered to be leukoplakias. Approximately 3% of the world's population have leukoplakia lesions. 5 to 25% of these lesions are pre-malignant. Thus, until proven otherwise by means of histological evaluation, all leukoplakias must be considered precarcinous. On histologic examination, they present a spectrum of epithelial changes ranging from hydrokeratosis or line thicket, acanthotic but orderly mucosal epithelium, to lesions with markedly dysplastic changes, sometimes merging into carcinoma in situ. Related to leukoplakia, but much less common and much more obvious, is erythroplakia, which is red, valve T, possibly eroded area within the oral cavity that usually remain level with or may be slightly depressed in relation to the surrounding mucosa. The epithelium in such lesions tends to be markedly atypical, and the risk of malignant transformation is much higher than is leukoplakia. Intermediate forms are occasionally encountered that have the characteristic both for leukoplakia and erythroplakia, termed speckled leukoerythroplakia. Both leukoplakia and erythroplakia may be seen in adults in any age, but they are usually found in persons aged 40 to 70 with 2 to 1 male predominance. Also, these lesions have multifactorial origins. The use of tobacco is a common antecedent. Aphthous ulcers are common, often recurrent, exceedingly painful, superficial oral mucosal ulceration of unknown etiology. They affect up to 40% of the population and are most common in the first 2 decades of their life. Aphthous ulcers tend to be prevalent within certain families and may also be associated with immunologic disorders, including celiac disease, inflammatory bowel disease, and Becher disease. The lesions appear as single or multiple shallow hyperemic ulcerations covered by a thin exudate and ringed by a narrow zone of erythema. The lesion typically resolves spontaneously in 7 to 10 days, but may sometimes persist for a week, particularly in immunocompromised patients. The underlying inflammatory infiltrate is at first largely mononuclear, but second bacterial infection may result in a neutrophilic infiltrate. Traumatic ulcers are caused by trauma, usually on the buccal, mucosa tongue, and lower lip, and are indistinguishable histologically from recurrent Aphthous ulcers. On this slide, see its fibrine membrane with underlying granulation tissue and acute and chronic inflammation, not adjacent traumatic parakeratosis with surface bacterial colonization. D on this slide with acanthosis, many spangiotic pustules, intraepithelial hemorrhages, and reactive epithelial ectasia. Actinic cheilitis is a pathologic condition affecting mainly the lower lip, and it is caused by chronic and excessive exposure of the lip to the ultraviolet radiation in sunlight. In comparison with the skin, which reflect from 5 to 10% of the ultraviolet, radiation and absorb 70%, especially through melanin. The lips is less protected because of its thin epithelium, thin layer of the keratin, and lower amount of melanin and lower secretion from sebaceous and sweat glands, which make the lip more vulnerable to damage by radiation. Actinic cheilitis is a characterized precarcinose lesion of the lip. If you talk about clinical presentation, there is a loss of usually sharp border of the lip, atrophy of the vermilion border, and darkening of the lip at the border between the lip and the skin of the surface of the face. As the lesion progresses, rough and scaly areas develop, which become thick, especially if they stand to the wet line of the lip. Chronic focal ulceration can occur in one or more sites, as well as leukoplakic lesions. Hyperkeratosis or parakeratosis and acanthosis are universal aspects. Also, areas of atrophy are not rare. The lamina propria shows blood vessels often dilated and vascular prominence due to increased volume of endothelial cells and not their proliferation. Presence of solar elastosis is a frequent and important sign. Still, in the dermis, there is a presence of inflammatory infiltrate of the intensity varying from mild to severe, which is composed predominantly of lymphocyte, but also with distinct participation of plasma cells and eosinophils. Keratinocyte ATP is the most important aspect. It gradually settles in the epithelium. Mild to very severe degree of epithelial dysplasia can be found, and the potential to development of invasive carcinoma increases with the severity of the change. More severe cellular ATPs may be associated with intensive inflammatory condition, often observed in ulcerated AC. Nicotinic stomatitis is also known as nicotinic leukokeratosis of the plate smokers. Plate smokers keratosis is a benign disorder of the lining of the palate that is seen in smokers, especially pipe smokers. The clinical picture is very characteristic, the result of diffuse hyperkeratosis of the palatine epithelium with chronic inflammation of the palatine glands. Flatted, indurated gray-white papules of 1 to 3 mm in diameter produced by the detachment of the keratin plaque over the inflamed memory salivary glands. The lesions are asymptomatic and located in the posterior tooth or two-thirds of the hard palate and may extend to the soft palate. With evolution, the picture acquires more intensity, and the whitish, fissured keratotic component predominates over the glandular inflammatory component. Histologically, in nicotinic stomatitis, hyperkeratosis, parakeratosis, acanthosis, edema, and inflammation by plasma cells in the dermis are observed, and at the level of the mineral salivary glands, dilation of the excretory ducts with keratin plaques, squamous metaplasia in the glandular duct, and infiltrates can be observed. A fundamental fact is that nicotinic stomatitis lesions do not have a risk of malignancy. Oral hair leukoplakia, it's a white confluent patches of the hairy mucosa, bilateral along lateral tongue. It's associated with HIV positive patients. AIDS may be appear within 2 to 3 years, but actually due to EBV infection. Clinical features, it's white patches that can have a folded surface that cannot be rubbed off. May be quite extensive and bilateral and involve dorsal tongue. These revealed epithelial thickening, but due to acanthosis and hyperkeratosis, areas of ballooning cells, pycnotic looking considerate nuclei, in a few places and no association with inflammation. Definitive diagnosis of HL involves demonstration of EBV using electron microscopy, immunohistochemistry, or molecular biology methods such as in situ hybridization. The lesions eliminates EBV molecular biology and has focused attention on the role of epithelium in EBV biology. There's a relative lack of Langerhans cells, while initially associated with HIV, immunosuppression and progression to AIDS, HL, is seen also in association with other forms of immunodepression, immunosuppression, such as organ transplantation patients, those with lymphoproliferative diseases, and in association with steroid use. HL was later described in rare, apparently immunocompetent individuals, and this seems to be an increasing context for its presentation. Congenital craniopharyngeal syndromes, and first of all, it's Crouzon syndrome. Crouzon syndrome is characteristically inherited syndrome characterized by cranial synostosis, premature fusion of coronal sutures, resulting in the skull and facial deformities. This syndrome was described in 1920 by a French physician, Dr. Crouzon, when he identified both a mother and a daughter with what was originally called craniofacial synostosis or dysostosis. He described a triad of skull deformities for facial abnormalities and proptosis. The triad of findings was then relabeled Crouzon syndrome. Crouzon syndrome is inherited in an autosomal dominant pattern and caused by a mutation in the fibroblast growth factor receptor FGFR2 or FGFR3 on chromosome 10. This process results in the premature fusion of sutures, the complexity of which and why a specific suture is involved is not currently known. Depending on the sutures involved, different abnormal pattern of growth of the skull can occur. Another one syndrome is Apert Syndrome. Apert Syndrome is a rare disease and estimates to occur in 1 in 75,000 to 200,000 births, depending on the study cited. Apert Syndrome is another genetically inherited syndrome characterized by cranial synostosis, its premature fusion of coronal sutures, resulting in skull and facial deformities and syndactyly. The syndrome was first described in 1906 by French physician Eugen Apert, when he described 9 people with similar facial and extremity characteristics. Apert syndrome is an autosomal dominant inherited cranial synostosis syndrome. It's due to gain of functional missense mutation of fibroblast growth factor 2 FGFR2 on chromosome 10q. Patients with Apert syndrome have cranial synostosis, mid-phase hyperplasia, and asymmetric syndactyly of the hand and feet. The cranial synostosis is more severe than that found in Crouzon syndrome, and the additional finding of syndactyly helps confirm the diagnosis between multiple single syndromes in regards to their phenotype. There are other craniofacial abnormalities found in Apert syndrome and other cranial synostosis such as acrocephaly, proptosis, prominent forehead, or hypertelorism. Pfeiffer syndrome is an inherited craniofacial syndrome that is associated with primary cranial synostosis, mid-phase hyperplasia, broad thumbs and great toes, and soft tissue syndactyly of hands, usually second to and third digits, and feet of varying severity. Most of the affected patients have associated conductive hearing loss. PS type 1 associated with mutation in FGFR1 and FGFR2. PS type 2 and type 2 are associated with mutation in FGFR2. Characteristic facial features of PS result from the premature fusion of the skull bones. Abnormal growth of these bones leads to proptosis, whites at eyes, high forehead, and undeveloped maxilla, and breaked nose. Patients with PS may manifest upper airway obstruction related to midface hypoplasia and secondary nasal obstruction. Experience with connective surgery is limited. Corrective surgery is limited. The main aim of surgery are to decompress the brain by providing adequate intracranial volume, increase the infraorbital volume to accommodate the globe, and to widen the nasopharynx. Pierre Robin sequence, PRS, Pierre Robin Syndrome, is characterized by the clinical triad of microglossia, glossoptosis, and upper airway obstruction. Clinically, this results in small undeveloped mandible that cause the base of the tongue to fall back into the throat and can ultimately lead to upper airway compromise. It is commonly associated with cleft palatin. Epidemiological data is sparse, and available evidence suggests that PRS affects approximately 1 in 8,500 to 1 in 14,000 newborn per year. The following are common theories behind the hypoplastic mandibular growth: its mechanical theory, neurological maturation theory, and mandibular compression theory. Treacher Collins Syndrome, also called mandibulofacial dysostosis, is a rare congenital disorder of craniofacial development and has variable phenotypic expression. Greater than 50% of the cases are sporadic mutations. Also, familial cases are well known. In familial Treacher Collins syndrome, the most common mode of inheritance is autosomal dominant, and TCOF1, POLR1C, and POLR1D gene mutation are the most commonly implicated. The most common clinical manifestations include downward slanting palpebral fissures, mandibular hypoplasia, and malar hypoplasia, coloboma of the lower lompile, malformation of the auricular pinna, and middle ear deformities, and associated conductive hearing loss. These clinical features are usually symptomatical and bilateral. Next one is tongue development abnormalities. Microglossia is a very rare condition with approximately 50 cases reported in the literature. Frequently, this disorder is present in association with lip abnormalities and is grouped as a hypoglossia, hypodactylia syndrome. A conclusive etiology for microglossia remain unknown at this time. However, several theories have been postulated. Certain medication used during pregnancy, such as diazepam, meclizine, and T-gun, have been thought to possibly contribute to these conditions. Another proposed risk factor is hyperthermia in utero, especially in association with Morphology syndrome. There is no substantial evidence for heredity or sexual preferences and development of microglossia. Congenital syndromes associated with some cases of microglossia or aglossia include Hanhart syndrome, Charlie M syndrome, Robin sequence, or Nebula syndrome. Several cases of microglossia have been associated with situs inversus or dextrocardia. Macroglossia is a disorder in which the tongue is much larger than normal. Macroglossia is the most often caused by increase in the amount of tissue on the tongue rather than by the growth, such as a tumor. This condition can be seen in certain inherited or congenital disorders including acromegaly, backweed, Weidman syndrome, congenital hypothyroidism, diabetes mellitus, Down syndrome, lymphangioma, hemangioma, mucopolysaccharidosis, primary amyloidosis is much more rare. Ankyloglossia or partial is defined as a limitation of the possibilities of the protrusion and elevation of the tip of the tongue due to either the shortness of the frenulum or the gyneglossus muscle or both. It seems to have a genetic etiology and normally occur in children between 1 and 3 years old. Its diagnosis is clinical functional. It is considered that there is a hypertrophic lingual frenulum where the tongue mobility is reduced. The limitation in lingual mobility in neonates could cause 3 alterations in breastfeeding. It's soreness, cracked nipples, and mastitis of the mother, poor weight gain of the newborn, excessively long periods of time in each breastfeed. Fissured tongue is a common variant of the tongue that has numerous grooves and fissures on the dorsum of the tongue. Males are more commonly affected. The condition may be seen in any age, but generally affect the older people more frequently. The etiology is largely unknown too, but studies have shown that heredity plays a significant role. Aging and local environment factors may also contribute to its development. Fissured tongue may present as an independent manifestation or associated with certain underlying syndrome or familial conditions. Conditions associated with fissured tongue include Mucosa, syndrome, Down syndrome, acromegaly, Sjogren syndrome, or facial granulomatosis, psoriasis, and geographic tan. Congenital lips abnormalities. Upper lip tie is uncommon case which make it difficult for babies to feed breast milk. It is revealed by researchers that upper lip tie and tongue tie can make a functional problem, but almost no one had bony abnormality caused by lip tie. And in most cases, it is not treated if there is no limitation of baby's growth result for difficulty of breastfeeding. A short frenulum of the upper lip is often the cause of the formation of diastema, a wide gap between the central upper incisors, malocclusions, speech impairment. Four-side spots. Four-side spots are heterotopic sebaceous glands that can occur in the vermilion border of the lip, within the oral mucosa on the penile shaft, usually the ventral surface, scrotum, areolar region of the breast, and labia minor. Four-side spots in the oral mucosa are very common. Biopsy of the lesions revealed ectopic sebaceous glands consistent with the diagnosis of four-side spots. Treatment is not necessary since it is an anatomical variation and a benign condition. However, for cosmetic reasons, in the distressed patients, dissection, radio frequency ablation, micropunch technique, or even laser ablation can be offered. Odontogenic infection is defined as those infections that originate from the pulpal or periodontal pathology that affect the alveolar bone and can spread through the bone marrow, cortical bone, and periosteum to structures distant from the oral cavity. OI is one of the most common diseases, accounting for 60% of reasons for dental consultation with a dentist. The main etiology is dental caries, but it can also develop from pericarditis, periodontal pockets or exodontia. The severity of the infection depends on multiple factors such as virulence of the bacteria, the systemic state of the patient, and the anatomical space affected. Dentogenic infection can lead to sepsis, a potentially life-threatening condition caused by the body's immune system responding abnormally. This can lead to tissue damage, organ failure, and death. A patient with non-oncogenic related infection could also present with sepsis at a dental practice. OI is polymicrobial with a high prevalence of gram-positive cocci and gram-negative rot, being the streptococci the most prevalent. There is a 3-to-1 ratio of anaerobic to anaerobic bacteria. Anaerobic bacteria are found in 75%, while the aerobic bacteria are found in 25%. The increment in bacterial load increases the diversity of microorganisms. When interacting among them, there is a synergism that increases their virulence. The dissemination of OI occurs by three routes. It's by continuity through anatomical spaces, which being virtual spaces and not having real physical limits, facilitate the spread of the infection between them. By gametic route, when entering the circulation system. By lymphatic route, when entering the lymphatic system of the head and neck, it can spread through the lymph from the primary nodule close to the infection focus to the secondary nodule in a distant site. It has been reported that the most frequently involvement epineurotic spaces is the vestibular spaces, 50%, while other studies concluded that it was the buccal space is 60% and some submandibular spaces is 35%. Beyond these differences, it was concluded that odontogenic infections are responsible for 43 to 60% of deep neck space infection. Physical examination of the patient plays an important role during diagnosis. In advanced stages of OI, an iteration of vital signs along with leukopenia manifested as a systemic inflammatory response syndrome. Temperature is lower than 36 or higher than 38 degrees centigrade. Heart rate is 90 per minute. Respiratory rate is much more than 20 per minute, and neutrophil count is 12,000. Three stages can be determined during the examination of patient or with OI. It's inoculation, cellulitis, or abscess. The classic signs of and symptoms of inflammation are evidence as pain, reddish, heat, edema, and loss of function. Depending on the severity of the infection, thermal elevation, diaphoresis, general malaise can be present. Some of the signs and symptoms are indicator of an infection that requires in-hospital management by a specialist. Ludwig's angina is the form of severe diffuse cellulitis that are present in acute onset and spread rapidly, bilaterally affecting the submandibular, sublingual, or submental spaces, resulting in a state of emergency. The Ludwig's angina, the submandibular spaces, is the primary site of infection. The majority of cases of Ludwig's angina are odontogenic in etiology, preliminarily resulting from infection of the second and third molars. The root of these teeth penetrate the reach such that any abscesses or dental infection has direct access to the submaxillary spaces. Once infection develops, it spreads continuously to the submandibular spaces. Infection can also spread contagiously to involve the pharyngomaxillary or retropharyngeal spaces. There will be inserting the airway. Other causes include peritonsillar or peripharyngeal abscesses, mandibular fractures, oral ulcerations, or submandibular celluloidinitis, and the oral malignancy. Is an infection that affect the cerebral sinuses. Because being don't contain valves, blood flow arrives from several directions, connecting the cavernous sinus to the face through the angular vein, which connect with the superior ophthalmic vein, and to the palate through the pterygoid plexus via the inferior ophthalmic vein. When infection reaches the cavernous sinus, regardless of the route, births occur. However, infection from the canine region via the angular vein are more frequent. Ophthalmoplegia, loss of infraorbital or supraorbital sensitivity, mydriasis, pentabroptosis, and emerosis can be observed in patients. Cerebral sepsis, pathophysiology of the sepsis. Several elements are crucial in the progression of the disease, such as a release of large quantities of pro-inflammatory mediators, complement activation, and dysregulated coagulation. Moreover, some individuals may be genetically susceptible to development sepsis. The excess inflammation from sepsis may be followed by immunosuppression, leading to organ dysfunction. Sepsis is defined as a systemic inflammatory response syndrome with proven or probable infection of bacterial, fungal, and viral origin. Severe sepsis is characterized by additional existence of organ dysfunction, while septic shock is defined as sepsis together with the failure of the cardiovascular system to sustain adequate tissue perfusion. Initially, the organism reacts with pro-inflammatory immune response to the infection stimulus. During the latter course of disease, there is a coexistence between SIRS and compensatory mechanism termed compensatory anti-inflammatory response syndrome. The results in sepsis-induced immune suppression is characterized by a collapse of cellular immune response and an increased risk of opportunistic infection with a high mortality. Clinical signs of sepsis are unspecific and comprise general symptoms as well as laboratory indications of an inflammatory or signs of hemodynamic impairment and organ dysfunction because of high variability of symptoms and the pathophysiological complexity, clinical recognition, and severity assessment remain difficult. Clinical and pathological anatomy distinguish four clinical and morphological types of sepsis. Each of these is nosology. First of all, septicemia, septicopemia, bacterial or septic endocarditis, but chronic cranial sepsis is currently not considered as a form of the sepsis. Septicemia is a form of sepsis that has a rapid course without septic purulent metastases with a pronounced hyperallergic reaction of the body. In most cases, septicemia is caused by gram-negative microflora. From a modern point of view, mainly from clinicians, septicemia is a toxic allergic or immune lesion of the blood and circulatory system in the presence of a focal inflammatory focus and bacteremia. The pathomorphology of septicemia first of all reflects the strongest intoxication and hyperallergia and include the following disorders: it's hemolysis of erythrocytes, hemorrhagic syndrome, vasculitis with fibrinoid necrosis of the vessel walls, interstitial inflammation of various organs, hyperemic changes in the spleen and lymphatic tissue, dystrophic changes in parenchymal organs. Septicopemia is the form of sepsis characterized by bacterial embolism from the entrance gate of infection with the formation of metastatic abscesses in many organ and tissues. Unlike septicemia, the disease does not have a violent course. The main role in the development of septicopenia belong to gram-positive pathogens. If we'll talk about pathomorphology, autopsy of the bodies of patients who have died from septicopenia, as a rule, find a septic focus usually located in the gate of infection with purulent lymphanginitis and lymphadenitis. In the era of the septic focus, in the area of the septic focus, purulent thrombophlebitis is found, which is the source of thrombobacterial embolism. The first metastatic abscesses appear in the lung, which is the lung. Then, when the pulmonary veins are involved in the processes, abscesses appear in the organs of the systemic circulation, the liver, for example, on kidney, subcutaneous tissue, for bone marrow, maybe it takes part of the purulent osteomyelitis, and the synovial membranes, heart valves, for example. So in this picture shows a case of septicopenia. You can see intravascular purulent embolus that located in the lumen of the artery of perinephral adipose tissue. At high magnification, a purulent embolus in the lumen of the artery is determined. The artery wall is infiltrated by polymorphous nuclear leukocytes from the site of the intima. The deposition of the masses of fibrin is noted. Septic endocarditis. Infective endocarditis or septic endocarditis is the endovascular microbial infection of the cardiovascular structures, including large intrathoracic vessels and intrathoracic foreign bodies. The characteristic lesions consist of vegetation composed of platelets, fibrin, microorganisms, and inflammatory cells, as well as leaflet disruption. The commonly accepted pathogenic theory is currently reported from endothelial injury with deposition of non-effective sterile thrombotic vegetation to transient bacteremia with microorganisms adhesion. Secondly, the pathology of infective endocarditis may be local, including valvular or perivalvular destruction, or distal, due to detachment of septic vegetation with embolism, metastatic infection, and septicemia. Right-sided endocarditis can be complicated by pulmonary artery embolism and infarcts, pneumonia, and lung abscesses. Left-sided endocarditis can be complicated by systemic embolism and by cerebral, myocardial, kidney, splenic, and intestinal infarcts, or maybe abscesses. Embolic events are the most common extracardiac complication associated with the infective endocarditis, with the incidence ranging from 22 to 43%. So thank you for your attention. Have a nice time.